Hi, and welcome to the Pediatric Cancer Data Commons second annual public webinar, Growing a Data Sharing Community. Many of you probably have seen me before. I'm Monica Palese, the Director of Operations for the Pediatric Cancer Data Commons program. I want to start out saying that we're so happy that you've joined us, and we're very much looking forward to sharing more about our work today with you. We especially want to thank those of you who are joining us from somewhere where it's very late at night or very early in the morning right now. It's so exciting for us to have you here from all over the world and join us for this webinar. Next slide. So we're going to start out today with a little bit of information about who we are and why we're here, especially for those of you who are joining us for the first time. We're going to have a brief review of highlights from the current academic year, which here in Chicago is July 2020 to the present. And then we'll discuss plans and opportunities in the future. And we hope to have about a 30-minute Q&A session at the end. Next slide. So a few reminders before we get started here. There is a Q&A function that you can enter your questions during the webinar at any time. We're going to collect all of them and address them during that Q&A session during the second half of the webinar. If you miss any portion of this webinar, we know it's 2 hours and that's a little bit long for some of you. If you miss any portion of it, we will be recording this and sending out the slides afterwards, probably in a week or two. You can also access the slides at any time at the link at the bottom in the blue bar at the bottom of the screen. For those of you who might have registered for the webinar at this link, you might want to clear your cache if it just takes you to the registration link. So if you have issues, just clear your cache and then try that link again and it should work. Last and not least, we absolutely love and appreciate any feedback that participants can provide us so that we can improve our experiences in the future. You can share feedback at any time with us at sam.am/webinar-feedback. And with that, next slide. With that, I'd like to introduce Sam Bolchenbaum. Sam is a pediatric oncologist and the director of the Pediatric Cancer Data Commons.
Great, thanks, Monica. Very excited to be here to show all of you the progress we've made in building our Pediatric Cancer Data Commons. And of course, we owe a lot of this success to those of you who are on the call today. So we're just super excited to bring you up to date. On my first slide, on the next slide, we have a picture of our team. And, you know, we've really built up a team with a lot of incredible talent. And to build data commons, it requires an incredible array of different skills, from governance and regulatory work to technical infrastructure to building data dictionaries to project management. And we've been really lucky to build a team that can really focus on seeing today. So we're very excited. The whole team is on. Had generous funding from groups like the Raleigh Foundation, St. Baldrick's, Leukemia Lymphoma Society, and many others. And more recently, we've been able to get some very generous contracts from the government to build out some of our data dictionary work. And I'll be telling you a bit about that work later today. And of course, we also apply for grants and other mechanisms to get funding. Funding is one of our major issues, and we'll talk a little bit at the end about sustainability, but we're just so grateful for all of the work that all the fundraisers have done to get the commons started and to keep it going. So the next slide is what our driving principles are. We really we want to connect researchers together and connect people from all over the world. And we want to provide a way to lower the bar to research, to share data. We want to collaborate and to derive consensus for all the work that we do. And we want to make sure that everything we do is interoperable and shareable. And the end result, of course, is to provide better cures and treatments for kids with cancer. And we think that having high quality, easily accessible research data is really what's going to drive discovery. And at the end, I'll give you some of my thoughts about why I think the future of pediatric cancer care is really founded in these roots. So on the next slide is just some very brief background about what a data commons is and why we need one. A data commons is it's a place where all the data can speak the same language. We don't have to worry about somebody who collected data in Japan versus somebody who collected data in the US. and not being able to combine those data, we create a way for all the data to be in the same format and the same language so that we can share it. Of course, we all know pediatric cancer is extremely rare, and we have to bring data together if we have any hopes of being able to make the kinds of discoveries that we want to. No single institution is going to have enough patients, enough kids to study. And so combining data from all over the world is really the key to studying pediatric cancer. Having a data commons allows us to streamline the process of bringing data in to aggregate and study. We can have a set of repeatable processes that we can use to find new data, to see if it is of high quality, to ingest it into the commons. And you'll be hearing a bit about these things today. One of the keys to a data commons is having centralized workflows. So if somebody develops a cool new algorithm for building building a classifier for a particular kind of cancer, other groups should be able to use the same algorithm on the same platform. We should have the tools available for everybody. We don't think that it helps to build these siloed areas of research and analytics. We want everything to be available so that others can benefit from all the work that's being done. And to that end, we also really strongly believe that if we go to the work of bringing data in, that data should really be used to maximum benefit. So data could be used for one study, and then we want that same data, if possible, to be used for many other studies connected to other data sources, and really to derive the most benefit from the data that we collect. So that's really why we think data commons are important. And I know that I've shown in the past lots of different types of data commons, and I think that we're really at a time now where data commons, the technology and the science and the data, everything is coming together so that data commons can really be realized in this wonderful way. The next slide is an example or a diagram showing where we're at right now with all of our consortia. We've worked hard to build a consortia for the different tumor types listed here, and you'll hear more about this today, but to us, this means bringing together people from around the world, establishing trust between groups, establishing rules of the road for how we share data, and we really now think of this as a consortium of consortia. And while that sounds funny, it's exactly what it is. We have a big group of pediatric cancer consortia all together. And although each of these groups is working independently to collect and harmonize data and to study the data, we're now thinking about a larger structure where we can use the same tools and techniques across the groups. And ultimately, we want to be able to leverage all the data together when necessary to make more and more discoveries about pediatric cancer. The next slide is really showing the bigger view now, where we have all of our consortium of consortia in the center, and now we have to have governance over that group, right? So we have to have a governance group, and then we have to have a way to build data dictionary over all those consortia. We have to have the right kind of project management. You'll be hearing about how we engage the different groups today, and then of course building analytic tools is key. And on the right side of the slide is showing how we are very passionate about connecting out to other data commons. And one of the whole goals of having a data commons is being able to connect to other platforms, combining data sets together. And as many other commons emerge now, we are in an excellent position to provide ways to connect those commons and to share the data and to build even newer data sets that we can study to make more discoveries. And then my last slide is really showing how we got here. This is really been an incredible journey. So neuroblastoma led the way over the last almost 20 years of building a dictionary and collecting data. And it's been over the last 8 years now that we've set up the first commons. We had the opportunity then to build the rhabdomyosarcoma commons. And then as you see here, we've now brought in many other groups over the last 3 years, ALL, Hodgkin, CNS, germ cell tumors, and others. We've built this really great governance over all the work that we do. We've set up now cohort discovery tools that you'll see today, and we're bringing on new consortia all the time. And so we'll talk a bit about some of the newest consortia that we've launched. Recently, we had a knowledge exchange that was very well attended, where we were able to share some of our new discoveries. It's really been an incredible journey, and we've picked up a lot of steam in the last 2-3 years, and we're really hoping to keep pushing forward. And today really represents the culmination of a lot of the work that has gone on over these last 2 or 3 years, and that's why we're so excited to show you where we've been and now where we're going. So now I'm going to turn it over to Kat Blumhart, who's going to give us some background on the community effort it takes to build and implement our data commons. So Kat.
Hi. As Sam said, my name is Kat Blumhart, and I'm a project manager with the PCDC. Today, I'm going to be telling you a little bit more about the different components of the PCDC and how they work together to create a resource that's beneficial to the entire cancer data community. Next slide. So in order to explain the PCDC in a little more detail, I'm going to compare it to a community garden. At the PCDC, we create a shared space where many members of our community can come together and create and manage a data commons, similar to how a community comes together to plant and tend a community garden. We cultivate this shared resource, and then we're all able to share in the success. Next. So digging a little bit deeper into our community garden metaphor, the data that we store and tend in the PCDC garden represents the seeds. At the PCDC, another one of our primary responsibilities in creating a data commons is to create effective data standards that define what data needs to be collected and how we're going to collect it. Those data standards that we use to manage data are like the care instructions that you use when you go to plant a garden. Next. In order for our data commons to thrive, the PCDC needs to have a robust technical infrastructure. This infrastructure is represented by the healthy soil that keeps our seedlings in a garden strong. Next. As I talked about in the beginning, the PCDC team, the data contributors, and all of our collaborators around the world are an integral part of growing and maintaining the commons. So like a community garden, it's collaborative across the community gardeners. The PCDC is a shared effort in this way. Next. The PCDC team also works to ensure that all of the data that we accept into the commons meets our high standards using quality assurance and quality control processes. In our garden metaphor, this is like when a gardener removes bad seeds or does some weeding to clear out the garden space. Next. The PCDC governance also helps protect data in the commons so that only approved users are able to access it. Each disease group consortium has its own executive committee and governance rules that act as the fencing around each garden bed in the metaphor. So on this slide, you can think of each of those garden plots as the individual disease group consortia. The overall governance of the PCDC, including some of the newer things that we'll talk to you about today, like the Scientific Advisory Committee and the External Advisory Board, those represent the fencing around the whole PCDC community garden. And of course, all of these fences have gates, which allow the gardeners and the community members to move in and out through controlled processes, just like our data in the PCDC moves in and out through controlled processes. Next. In order for the PCDC to thrive, we need to engage with everyone, from the people who collect the data, people who use the data in their research, students and young investigators, and the larger pediatric cancer community as a whole, including patients whose data is the foundation of the PCDC's work. These connections and relationships that we're able to build are the sun and the water that feeds the community garden in our metaphor. They're vital to every part of the process. Next. In order to explore data in the PCDC, as most of you know, we have cohort discovery tools that allow users to see what data is included in the commons and to better understand the research questions that those data could answer. These tools are the paths and signage in the garden metaphor that direct the community and allow all members to see what's available in the garden and where it's located. Next. Finally, the PCDC team and all our collaborators share the effort that allows the data commons to reach its full potential. This whole community represents the gardeners, and just like the community in our garden metaphor, we all share successes by being able to release the data stored in the PCDC to researchers. This final step represents how our PCDC garden feeds our cancer data community. Next. So for the next part of today's webinar, we're going to be sharing some highlights from the past year across these 4 main areas of our work: the governance, which, as you remember, represents the fences in the garden; the data standards, which are the seed instructions for how to plant and tend our seedlings, the technology, which is the fertile soil, and the engagement, which is the sun that helps our garden grow big and strong. With that, I will hand off to Monica, who will introduce our next section.
Thanks, Kat. Next slide. So we're going to start out again, as a reminder, discussing what's happened in the past year. So we're strictly speaking about what's happened since July of 2020 through June of 2021. We know that the current academic year isn't quite finished, and we've got quite a bit more work to do in June. But for the purposes of the next few sections of this presentation, we're going to be talking about just July to the present. Next slide. So looking at the PCDC as a whole, in the past year, we've had several exciting milestones. What we're going to highlight here is just scratching the surface of what our team has been able to accomplish. And again, each group will go into it in further detail in this next part of the presentation. At a high level, we have 10 disease groups in total now engaged. 4 of these consortia have signed a memoranda of understanding this year. Those would be Hibiscus, which is our bone tumors group, Nodal, which is our Hodgkin lymphoma group, Interact, which is acute myeloid leukemia, and Magic, which is the germ cell tumors group. We also have 13 active sources of funding and several data dictionaries in progress. So there's 2 new disease-specific data dictionaries that have been completed, as well as 4 data dictionaries that we've been working to integrate with the NCI thesaurus. Next slide. So the data here, or the highlights here, are again speaking across all of the data commons. There's over 26,000 total cases in the iNRG and Instruct data commons to date, with 1,138 new cases added this year. I believe that equates to 793 from the Children's Oncology Group and 345 from SciPen, both of which have been updated into the iNRG data commons in the last year. We've had 7 publications, 7 posters and presentations, and 5 new research projects approved. If my math is correct, this is 1 paper and 3 presentations from the iNRG, 5 papers from Instruct, and then 1 paper and 4 presentations from the PCDC, with more on the way. Next slide. So this is a high-level overview for those of you who have been receiving our newsletters. You're probably familiar with this graphic. This is kind of a progress tracker across each of our 10 disease group consortia. Next slide. And here you can see where we've made progress, in particular in the last year. We've had several new disease groups added since this time last year, as well as those 4 memorandum of understanding that I mentioned in the last slide. Next slide. So this is a map representing where our current data contributors are from. This is across the iNRG, Instruct, Magic, Interact, Nodal, and Hibiscus consortia, and the continents from which they collect data. If you go to the next slide, the highlighted in yellow groups are the ones that are new as of 2020 to 2021. So as you can see, we're rapidly onboarding additional collaborators each year, and we're very excited to have these new groups on board. Next slide. Lastly, we just wanted to give a special thanks. Again, this is just the 13 active funders for this year. We're really excited that additional funders have already signed on to fund projects starting July of 2021 this year. But we wanted to acknowledge those who have actively been funding us this year and say an extra thank you for all of your support and all of your support in what we've been doing along the way, not just this year, but in years prior. And with that, next slide. Now we're going to get a little bit more into detail about the highlights of the last year by topic, as Kat had mentioned earlier. We'll start with Susie Burrs, who's our governance expert. Susie will tell us more about consortium governance, or the fences and gates of our garden, as well as data governance, which is our quality control or weed control. Susie?
Thank you, Monica, and welcome everyone. I'm going to talk, as Monica mentioned, about the fencing and the gates. Next slide, please. The consortia structure that Sam reviewed is enabled by a memorandum of understanding, which establishes each disease consortium. And as Monica highlighted in the progress tracker, this year has welcomed the establishment of 3 new consortia: Interact for AML, Nodal for Hodgkin, and Hibiscus for bone tumors, which includes both Ewing sarcoma and osteosarcoma. Additionally, MAGIC, which was established in 2009, entered into a memorandum of understanding consistent with the operations of the PCDC. We thank all of the leaders who worked to establish these consortium and join INRG for neuroblastoma and Instruct for soft tissue sarcoma. We look forward to continuing the consortium development activities with ALL, Inspire for CNS tumors, Global Reach for retinoblastoma, and C3P for childhood cancer predisposition. Next slide, please. Each disease consortium maintains autonomy, and through the responsibility vested by the Memorandum of Understanding to each consortium executive committee, they decide what data are brought into the disease data commons and what projects are approved. We start with data contributor agreements between the University of Chicago and each of the disease consortium members. As you can see, we have executed a number of DCAs over the past 6 months. 4 data contributors of germ cell data for MAGIC, including Medical Research Council in the UK, Dana-Farber Cancer Institute, Foundation IRCCS for the AEIOP data, and Gustave Roussy for the SFCE data. We updated the agreement with the Japan Neuroblastoma Study Group for INRG, and we have a new agreement with the Japan Children's Cancer Group for AML data for Interact. Next slide, please. These are the projects or requests for data which have been approved by the respective executive committee. There are 2 governance gates before data are provided to the principal investigator. In addition to the Disease Consortium Executive Committee approval, data use agreements are executed as needed between the University of Chicago and the institute of either the principal investigator and or the statistician who will be analyzing the data. This is a list of recently approved projects. In addition, as detailed on the progress tracker, INRG and Instruct have published manuscripts and projects in flight. Next slide, please. Even while each consortium maintains autonomy for the research, for the operations of their consortium, in recognition of the growth of the PCDC, we are establishing a scientific advisory committee, which will be composed of key stakeholders, including representatives of each consortium and representatives with specific skills, such as statistics, regulatory, and ethics. The SAC provides strategic and operational guidance for the pediatric cancer data commons while maintaining the autonomy and scientific direction of the disease consortium. The SAC will help us address the extension of data types to genomics, imaging, tissues, histologies, and other data which might be identified, and ensure that the PCDC has an appropriate, sustainable, and ethical approach to linking the clinical data across diseases and with these additional data types. The External Advisory Board, or EAB, offers insights and feedback from an outside group of clinical, data science, and digital health experts who will share their experiences and offer strategic advice on initiatives of the PCDC. We want to give a special thank you to everyone who helped us workshop these new governance groups. Next slide, please. This diagram illustrates that the SAC and EAB will have lines of communication with each other, with the PCDC consortia, and with PCDC workgroups. Any report issued by the EAB will be provided to the SAC and therefore to the PCDC stakeholders, as well as PCDC leadership. These communication lines reinforce the foundation of trust upon which the PCDC is built. Next slide, please. To support the growth of the PCDC, we have implemented some standard processes, as well as assisting the consortia establish processes to help the executive committees complete their required responsibilities. We are delighted to announce the publication of the PCDC privacy notice. You will find this on the footers of our PCDC website and the current INRG and Instruct cohort discovery tools. This privacy notice explains how our organization uses the personal data we collect from you when you visit our websites. We have implemented the standard procedures for establishing a disease consortium through the execution of a memorandum of understanding between the cooperative groups and institutions founding the consortium, which leads to the creation of the executive committee. We also have standard procedures for working with data contributors to execute the required data contributor agreement with the University of Chicago, enabling the PCDC to receive the contributed data. And to complete the gates that I mentioned earlier that are needed for the provision of data for approved projects, we have a standard process for executing data use agreements between the institution or the investigator receiving the data and the University of Chicago. As the consortium executive committees are launched, there are operational workflows that they have to customize to meet their specific concerns. Focused attention is given to the publication policies and project request forms, which detail the project request review process and authorship guidelines. Simultaneously, the executive committees establish the cadence for their meetings and determine the work groups or subcommittees that are needed. These areas, projects, and work groups are key to advancing the scientific mission of the consortium. Next slide, please. Data governance is necessary to ensure high-quality data is positioned to help researchers answer questions which cannot be asked through other means. One set of controls are the data dictionary procedures, which ensure that data dictionaries are developed in a consistent manner and that changes are carefully reviewed to meet the requirements of the disease while also accounting for any impact to the same element used in other disease data dictionaries. Related, there's a procedure for the establishment of the disease-specific quality control checks to feed into the quality control program. Another set of controls ensures that we have a set of standard procedures for receiving data and a standard procedure for providing data for an approved project. Next slide, please. Our data control program gives data contributors and our users confidence in the data that they will use for their research. There are 3 steps to verification and validation. First, we check the integrity of the file and ensure that it survived the journey through cyberspace. Next, we check that each data element conforms to the data dictionary. For instance, is it present if it's required? Is it an integer if that's what we're expecting? Is it within the range of acceptable values if there's a value set? And next, we check the internal consistency of each patient record. For instance, we check that the diagnosis date is not earlier than the birth date. We check a patient in stage 1 does not also have metastasis. The quality control program categorizes the validation checks as red, meaning that we cannot load that data into the data commons, yellow, that a fix has been identified for that error, or green, that the error is acceptable. This report of the findings is then sent to the data contributor, and there are discussions with the data contributor and the PCDC team to determine the actions to be taken for any of the errors in the data submitted which meet these criteria. Let's take a closer look at this. Next slide, please. For a detailed look, see data quality checks 1 and 2. The check is to make sure that the data are consistent. That is, if a patient is stage 1 through 3, that patient, by definition, does not have metastatic disease. Conversely, if the patient has metastatic disease, that patient cannot be staged as 1, 2, or 3. This check does not assume which one is right, only that they're mutually exclusive. And then that report is provided to the data contributor, and the data contributor might be able to go back to the source data and fix this error, or we might have to remove that patient record completely prior to loading the data into the commons. Once all the quality control checks are resolved, the data are ready to be loaded to the data commons and then be available for cohort discovery. When the data are supplied to researchers, we advise them on any of the data quality conditions that might impact their research. That's an overview of the consortium and data governance. And now I'll turn it back over to Monica. Thank you for your time.
Thank you so much, Susie. With that, we'll welcome Sam back to talk about our work over the past year, developing and applying data standards. In our garden story, these are the instructions that tell us what each seed is, and they're essential for the garden to grow. Sam?
Thanks, Monica. Okay, so I'm going to give you a little bit of an update on some of the data standards we've worked on over the past year. So next slide, please. So we did a lot of data dictionary work this year. We've completed data dictionaries for Ewing sarcoma and osteosarcoma, and our Hodgkin lymphoma dictionary has made great progress. And all of our dictionaries are available for public download, and we've been able to share them with many groups that are now utilizing our dictionaries for their own work. And it's very gratifying as people ask us to have copies of our dictionaries. So as they're completed, we make them available. Importantly, we've made progress on a centralized data model for our pediatric cancer data commons. And what that means is there are some data elements that are common across all the cancers. Think of things like gender or race or ethnicity. And we want to make sure that as we collect these data values over all of our commons that they're consistent. And we've been able to now create a centralized data model, which is something that we're working with the National Cancer Institute on getting integrated into their national model. And then finally, we were working with the National Cancer Institute that maintains a thesaurus of many different data models. And we work with them on a regular basis to make sure that all the dictionaries that we build are integrated into the NCI's thesaurus, because this is an important reference tool for anybody who's building data collection forms or building other ways of collecting clinical trials data. Next slide. So the data models that we build, we need to make sure that they're flexible, right? Because different disease groups have very specific criteria for the kinds of data they collect. So whatever data model we build has to be extensible for any particular disease group to be able to collect the very specialized data that they need to. We also have to be prepared to have the case where there's sparse data, because especially as we go back in time, there are going to be many patients' data we have where we're missing lots of values. As studies have progressed, new data are collected, old values are not collected, and we have to make sure that whatever model we have is flexible enough to accommodate the presence and absence of values. And it's important also to note that there are certain types of data that we just consider out of scope. We don't want to be recalculating values that were calculated initially by the cooperative group. An example would be a particular stage for a patient, because stage is a combination of many different variables. Response criteria is another one, and response criteria are often defined in the protocol. So what we do is we're very careful to report the data as it's given to us and report that it came from the cooperative group. And then it's up to the researcher to understand what protocol was used to collect the data and to understand the finer distinctions between data that were collected at during different eras. And so that's actually an important part of the work we do, is making sure that researchers know when the data were collected, how it was collected, and what the definitions mean based on the protocol. Next slide. So I just wanted to give one example of the kind of data standard mapping that we're doing. This is a small example from the neuroblastoma data dictionary. And as I mentioned earlier, Sue Cohen and Andy Pearson were pioneers early on in building a neuroblastoma data dictionary with Wendy London's help, where every term was standardized over all the groups that were in the INRG. And they mapped their terms to numbers as shown here. And that allowed groups in the US and Europe and Japan to collect data in the same way by mapping to these numbers. But if you think about it, if there's a group that's not part of this neuroblastoma consortium and they want to collect data in the same way, they may not know what these numbers refer to. They're not universal. And so what we've been doing is we've been mapping data to universal values that can be used anywhere. So on the next slide, you can see that we map our values to something called C codes, and C codes are part of the NCI's thesaurus, and these are universal. So there you see the stage 1 code, and on the next slide, you can see that if you click that stage 1 code, it takes you to a web page at the NCI's thesaurus, which describes the stage 1, the INSS stage 1 classification. It gives you some idea about other terms that are related to it, and it really allows you now to, instead of having the numbers listed there, having these codes codes really allows you to have something that is universal and extensible. So a researcher in any part of the world can go to the NCI thesaurus, see how our group has done staging, and to download those codes and to use those terms in their own data collection forms. And we're doing this now across all of our data dictionaries, and where there are codes that don't exist, we work with the NCI to update those codes. Next slide. The NCI thesaurus is US based, of course. It's part of the US's National Cancer Institute, but anyone in the world can use it. It's an international resource. And the NCI thesaurus now lists us, the Pediatric Cancer Data Commons, as one of the main authorities on pediatric cancer data standards. And that's because of the extensive work we've done with the international community to develop and ballot these data standards. And the NCI thesaurus really helps us share all of the work that we've done with the international community. Next slide. So on the last slide that I'll show, I want to make the point that we're now working to integrate our dictionaries into other efforts that are going on in the US. So there's a large effort that I'll talk about at the very end to build a harmonized data model for all types of cancer. And our group has been contracted to integrate our data dictionaries into that harmonized data model. This is very exciting for us for many reasons. Of course, it's very validating that all the work that we've done over the past several years now is coming to fruition as we're able to integrate our data dictionary into this national landscape. And also going forward, we certainly hope to see that as groups move to collect more data for trials, they'll now leverage the standards that we've developed so that data can be collected in a way that makes it much more interoperable and much more easy to share. So with that brief update on standards, I will now kick it back to Monica, and Monica will introduce the next speaker. Next slide. Thanks.
Thank you so much, Sam. So next up, we have Luca Graglia, who's our software engineering manager. Luca will tell you about our progress last year in building and improving the technological infrastructure for the Pediatric Cancer Data Commons. In our garden, these are the soil and paths, the physical foundation for our work. Luca?
Hi, Monica, thanks. Hello, I'm Luca, and I'm gonna give you some tech-related updates. I'm gonna divide my slide in three main topics: GEARBOx, the PCDC data common, and auxiliary system around the main platform. Next slide. GEARBOx is a support tool to help matching a child to a clinical trial. We created a prototype and we're working to our first version soon. I'm not gonna dig too much into this since Sam will be speaking more about this tool later in this webinar. As of today, we loaded the LS pedal trials, but it can be expanded to any other clinical trials. The image you see in this slide is the most important page of the application as of today, where a user can type information about the patient on the left side and see a suggestion about possible matches on the right side. Next slide. As of today, the clinical trial from LLS are extracted mostly manually. They are transformed into Boolean equation and loaded into the backend. Then when the user using the application shown in the previous slide types information about the patient, those inputs will be used as input of the Boolean algorithm, and the user will see matches, possible matches, or not, or like the trials that are not a match. All of these comes with an explanation of which one are the criteria that make that trial not a match, or which one are the criteria that have not been satisfied yet for the possible matches, and so on. And this is the state of the art. We're working to improve this process, of course. And first of all, we're connecting our platform to an enrollment support system, like for instance, in the case of LLS, the LLS Nurse Navigator, where the user can gather more information about the trial that the patient matched to or not. And of course, this will be configurable also for non-LLS trial. We have an early prototype of a natural language processing approach to extract criteria from the protocols in order to make it more scalable, since it's very time consuming and you need a lot of skills to extract all those criteria. And we're adding non-LLS trial to the platform. Other steps that we're going to take is setting up an endpoint where trials protocol can be submitted to, or in general, we will implement a more automated system to add trials to our platform that is not just us selecting the trials manually. And we plan to connect to external sources, like for instance, labs, to be able to pull programmatically patient data and reduce the amount of work the user needs to do when inputting patient data. So for instance, a clinician will type a patient universe identifier, and if this person has the correct amount of permissions, then the lab data will be preloaded in the form. Next slide. Moving on to the data common platform. You will see also a demo of these a little later, so I'm just gonna give a brief overview of where we're at and what are the next steps. Among the many available functionalities on this platform, the most important one is the ability for the user to create a cohort of subjects. So the user, as you can see by this image, can apply filters and select a cohort based on some characteristic that he decided, then can generate a survival curve with the data from that cohort, and can even connect to external data that the subject has in other platforms. So today we're connecting with GDC for target data. We are building connection with Gabriela Miller Kids First, but in general, we are planning to spend a lot of time to improve this interconnection with other platforms a lot. Next slide. Another important functionality that we are adding to the platform is the ability for the user to request access to the selected cohort of subjects. So after the user defines one or more cohort, the user can submit a request to have access to that line level data corresponding to the selected cohort. So as we've seen before, the user will apply the filter, then click on a button to request access to the line level data. And this will start a process in the backend that will be handled by a state machine. The system will notify the user which consortium those data are coming from, and ask the user to upload all the required information. So for instance, resume information about statistician on the project, or a description of the project that the requester has in mind, and so on. At this point, all this information will be routed to the member of the consortium committee, and there are two main outcomes. So the consortium can approve this request, so the requester will get access to the line level data corresponding to that cohort of subject. The project request could be rejected, so in the case the process will end there, or the consortium committee could ask for more information, and then we'll start a conversation among the two parties that we circle back and forth until approved or rejected. And another functionality we're planning to add is the ability to have workspaces as part of the platform, which means that the user will be able to pull, when as the authorization, data from different data common and from different platforms, gather them all on a virtual machine, and be able to run analysis there. Next slide. This is my last topic of today's webinar. And I think it's also very important, even if it's not something that is easily seeable from the user. We spent a lot of time making sure that the data are translated accurately, and we're doing our best to make sure the quality of the data is as high as possible. We created a process that is still, of course, partially manual today, since we are in the way of building it, but we're trying to automatize it as much as possible to reduce human error and keep track of everything that happens to the data. We think that keeping track of lineage and provenance of the data is very important for many reasons. One, for instance, is because it allows to be more accurate over time. For instance, when a variable definition change, or there are platform and dictionary updates. So the process we are in the process of building is data contributor drop the file in a protected storage unit. If the data is already in the latest format, then they will just go through QA/QC scripts as basically rules like the one that Susie showed before to make sure that there are no inconsistencies with the data. And we've been working with statisticians from the different consortium to obtain these validation rules where present, and or we have been spending time creating the rule with them when they're not. In case the data are not coming in the latest version, then we will run a QA/QC script on the older data version, transform the data in the new version, run the updated QA/QC script version for that version, in order to make sure that there has not been data loss in the translation. Then the data will be transformed into the Gen3 files and uploaded to a protected storage for backup in a staging environment. Then periodically data will be released to production. Next slide, please. As of today, we have about 27,000 cases in the PCDC data common, about 22,000 from NRG and 4,500 from Instruct. And we're working to add soon data from the MAGIC and Interact consortium. These are some of the things we're working on. I hope you find this overview interesting. So thank you for your time.
Thank you so much, Luca. And then finally, to wrap up our highlights over the past year, I'll hand it off to Caitlin Pike, who's our communications manager. Caitlin will talk about the PCDC's engagement strategy, which is like the sun and rain feeding our garden. It touches every other area of our work. To touch on the engagement work that we've done over the last year, we have several groups that we've been working very closely with. We work with students, researchers, and physicians, as well as the wider community. And Caitlin will go into a little bit more depth on each of these groups in just a minute.
Monica covered our core audiences, which are the student community, the scientific and medical community, and the wider community, everyone who's affected by pediatric cancer. And these groups overlap. You could say that each of them is a subset of the next. And within those categories, there are also sometimes subgroups that are particularly important to address at one time or another. But these are the main three areas that I'll focus on today. Working with students and making sure they're involved in our work is really important to us because they are the next generation of researchers and doctors. When students work with us, they learn more about data standards and data commons, and they take that back with them as they continue their education. And in turn, we value the insights that they bring to our team. And the biggest way we engage with students is through hiring people who are midway through their medical education. And we've been fortunate to have 3 great students so far, 1 per year, who have taken a gap year from the Pritzker School of Medicine to come work at the PCDC as a clinical data standards analyst. And this is a mutually beneficial setup where they can make a meaningful contribution to developing our data dictionaries while learning more about data standards and how a data commons works. And in addition to this, we also involve students who are earlier in their education. Our team mentors students who are working on their capstone projects in the UChicago Masters in Biomedical Informatics program. And we hire undergraduate students to work on specific projects with us. We've worked with 3 UChicago undergraduates this past year through the university's Metcalf internship program. Next slide, please. So it might sound a little funny to say that one of our engagement audiences is our own collaborators. But when you look across 10 different disease consortia, we actually have hundreds of people who are contributing in various ways to building the PCDC. So creating ways to communicate and connect is really important for us, especially over this past year when we didn't have the usual opportunities to connect in person at conferences. So with that in mind, this past February, we held a big retreat style meeting where we had representatives from all 10 of our disease consortia. And because each of these groups is on a similar journey with the shared goal of collecting and harmonizing data and having it available in a commons, but some groups are early in this journey and some have been involved in this work already for many years. So we felt that even though they all have their own specific priorities and needs, there are a lot of ways that they can both learn from each other's work and maybe get ideas for addressing what could be common challenges across groups. So we held this meeting that we called the Progress, Insights, and Knowledge Exchange, which in some cases was the first opportunity for our collaborators to meet people from the other consortia who are doing the same work for other types of cancer. And each group gave a presentation and had a great discussion. And at this meeting, we also began to collaboratively lay the groundwork for the Scientific Advisory Committee, which Susie told you about. And we plan in that vein to have more meetings like this going forward that will be focused around specific topics so that everyone can continue to learn from each other and make decisions together. Next slide, please. And so beyond the collaborators that we already work with, our engagement also needs to reach the larger pediatric cancer research community. And of course, we want people doing research to be aware of the commons and know how to access it and use it effectively. So as we launch our Gen 3 platform, that's going to be a focus. But just as importantly, we want to have conversations about data standards in general, because that's really how we can reach our ultimate goal of shifting the research paradigm when everyone understands the potential for data to be collected prospectively in an interoperable way. And so that has relevance to many parts of the research and medical worlds. And we're grateful for our engagement work group here. And that group includes representatives from multiple different countries and specialties, and they help us prioritize and plan our efforts. We make sure to distribute regular updates on our work so that people who are interested can stay connected with us. And that means things like quarterly email newsletters, an annual report, and of course, webinars like this one. And Sam also gives many talks each year to groups and organizations that do work related to ours. And then beyond talking about the PCDC, we'd also like to grow into inviting more voices and participating in larger conversations about the big ideas in pediatric cancer research and data sharing in general. So we're working on developing a new program for that now, and we'll be sharing more about that soon. Next slide, please. And finally, I want to talk about engaging with pediatric cancer patients and their families. And these are the people whose medical data all this work rests on. And so it's really important to us that they have opportunities to feel informed and engaged and to have their voices heard. So as an initial step toward understanding the landscape here, we conducted a survey last fall of people who have been directly affected by pediatric cancer. So patients and survivors and their parents and family members. And we also conducted follow-up interviews with some of the people who responded to the survey so that we could learn about their experiences in more detail. And we were also able to have some informational interviews with leaders from cancer support groups and foundations, and they were very generous to share their time and insights with us. Next slide, please. So the survey that we conducted was primarily about how much people felt that they knew about the life cycle of their cancer data. So what kind of data was collected, how it could be accessed and used, how and where it was stored, how it might be repurposed, and then finally when and how it would eventually be destroyed. So across all those steps, the average level of self-reported knowledge that people replied was 3.2 out of 5. And that decreased a bit as you got later in the data life cycle. If you're interested in seeing more about what we learned from this survey, I won't go into it now, but our student intern, Abru, presented a poster about it last month at the Chicago Area Undergraduate Research Symposium. And so when we send out these slides, you can follow that link and you can watch her video presentation. Next slide. And so that survey and those interviews were a first step for us. We also learned from the survey that people ranked their interest in learning more about what happens to their data as 7.5 out of 10. So one of our next steps is just to compile and create more informational resources so that patients and families can feel empowered to know what happens with their data and how it can help others. And we want to work with organizations that support patients and their families to share that information with the people who want it. And finally, we also plan to include a patient and family advocate on our external advisory board when that launches, so that we can continue to make sure that these voices always inform our work. Thank you. And thanks for your patience with my technical difficulties. I'll hand it back to Monica.
Thank you so much, Caitlin. This wraps up our highlights from the past academic year. I'm going to hand it back to Sam now, who I believe will be taking control of the screen. So give us just a moment. And Sam's going to talk about where the PCDC is headed and what we're excited about starting soon. Sam.
Great. Thanks, Caitlin. Thanks, Monica. And I'm going to move ahead and spend some time talking about our short-term plans to start with. So the PCDC is working on most cancer types, as you've seen now. And if you look at the incidence of the different types of pediatric cancer, we're covering, about 3/4 of the types of cancer that kids get. The tumors listed here in dark blue are the ones that we're already engaged with. We already are working on MOUs and data dictionaries, and we're planning on pulling data into the commons. And then the tumors here listed in light gray are tumors that are on our short list of next tumors to add. We obviously need to work on Wilms tumor and non-Hodgkin lymphoma and other types of cancer. So we want to target all types of pediatric cancer, but of course we want to try to get at the most common types that are going to be important to researchers and to physicians and to families. We also are very interested in working on survivorship and long-term follow-up. Most children who develop cancer at least in developed areas, will survive their cancer, and long-term follow-up is becoming such an important issue to monitor the effects of their therapy. As newer therapies emerge, like immunotherapies, this follow-up is even more critical because we don't really know the long-term effects of these new kinds of treatment. There's lots of social and technical issues with long-term follow-up. After a child finishes their chemotherapy, or imagine a teenager who just finished their Hodgkin treatment, the last thing they want to do is to keep in touch and to keep giving us updates about about how they're doing. They go off to college, they go get jobs, they get married, and it's often very hard to find folks. And if you do find them, it's often hard to bring them back into the fold to give you updates on how they're doing and to get the kinds of testing done that they need. And on the other side, you have clinicians who just aren't well versed in how to take care of kids who have survived cancer. And so there's so many issues with long-term follow-up. I also didn't mention the fact that you need to reconsent kids once they turn 18 to collect more information on them. So if you can't find the child, how can you consent them? So there's a lot of issues that we're working through. There's, of course, many groups that have been doing this for years and years. And so we're not planning on reinventing the incredible work that's already gone on in survivorship, but we really feel that our data commons has a role and a function to serve in the area of survivorship, especially as we can link survivorship data back to all these other data that we're pulling into the commons. So we think it's very important for us to be working on survivorship, and we're engaging various partners in doing this to leverage the work that they've done. So we're very excited that we're launching a new platform for sharing our data. The platform is named Gen 3 or Generation 3, and it's actually the technology that was built here at the University of Chicago by Bob Grossman and his group for the genomic data commons. And all of our commons are going to be on this Gen 3 platform. Shown here are some of the various data commons that are already using Gen 3 technology. So we have good company here. By using the Gen 3 infrastructure, it will foster interoperability with other elements of the Cancer Research Data Commons ecosystem, which I'll show you coming up. And one thing that we're really passionate about is that all the work that Brian and Luca and their teams are doing can be folded back into the Gen 3 code, so that if we build something to help make Gen 3 better, other groups can use it. And we feel that's super important, that all of this open access code that we write is going to be available and part of the next generation of this platform. We're planning on launching widely the latter half of this year. The initial launch is going to include hopefully neuroblastoma, soft tissue sarcoma, germ cell tumors, and AML. And we're going to add more cancers, of course, as we get the data harmonized. Having the data harmonized to the data dictionary is one of our bottlenecks. And as we get more data into the new format, we, of course, can then put it into the commons. Anyone is going to be able to register and explore the data. And by explore, I mean to see the kinds of data that are there and how many patients are there. But if somebody wants to get access to line level specific data, they're going to have to get project approval, just like they would if they wanted to do a study with data. They need to apply and get the data to download, and we will only give it to them under those rigid governance control circumstances. So stay tuned for information about the Gen 3 launch. You can sign up for our newsletter at the link here, and at the webinar link that you have will take you to areas where you can sign up for this. So I'm going to try to do a quick demonstration here. Everyone loves the risk of a live demo. Okay, so this is what the Gen 3 Commons interface looks like. You can see there's 26,639 subjects in here. And if I go over to the exploration area, it will bring me to this view that shows some of the demographics for the patients that are in the commons. Here are the 26,000 patients. And on the left here are various filters that I can use to slice up the patients into different cohorts that I want to study. So in this case, I'm going to look at the INRG, the neuroblastoma patients here, where there's 22,000. So I'm going to click INRG for neuroblastoma, and immediately we'll filter down to those 22,000 patients. And now maybe I just want to study patients that have stage 4 disease. So I'm going to come over here to disease, and I'm going to go down all the way to the bottom where we have stage, and I'm going to pick stage 4. It already tells me there's 9,269 patients that meet that criteria. I scroll back up to the top, and there's my 9,269 patients that have stage 4 disease. Now I'm going to save this cohort so I can come back to it later. Neuroblastoma, stage 4. I'm going to save my cohort. So now that cohort I can come back to anytime later when I log in. But for now, let's say I want to look at the survival analysis of these patients. So again, this is all in beta testing right now, and we're looking at all these different features, and we're going through lots of different discussions about what we're going to make available publicly. Right now, we hope to make something like this available where you can see a survival curve immediately for the patients that you've selected. In this case, again, I've selected neuroblastoma patients that are stage 4, and this goes all the way back to 1985 when the data was first collected for that are in the commons. But something else I can do cool is I can now stratify. So if I look, for instance, under molecular abnormality, I can look at NMIC amplification as a stratifying variable. And so if I apply that stratification, here it shows me that patients that do not have NMIC amplification have a better survival than patients that do. This is a very simple example. Of course, this is a well-known phenomenon, but it just shows you the power of being able to quickly look at different types of data and to quickly look at different stratification variables. We think this is really important for discovery. We want users to be able to come in and use the commons to generate hypotheses. There are lots of statistical considerations, and we are working with lots of different groups on how we are going to govern this. And so what you see here may not end up being what's released publicly, but I wanted to give you a flavor of the kind of work we're doing. If we go back to summary view and go back here to the subject side, you see here it says target genomic data commons. This is one of the things we're most proud of now, is that we can link to other aspects of the data commons ecosystem. This says that there's 814 patients in this cohort that have genomic sequencing data available. So I'm actually going to select that cohort. And now there's 814 patients. And then I'm going to go make the cohort a little bit more specific. I'm going to just look at the patients that have differentiating neuroblastoma. Now there's 20 patients here. Now, what's so cool about this is that now I can actually link out to the genomic data commons and see these 20 patients. I go over here to click Find Cohort, select Data Commons. I'll pick the genomic data commons and I'll open it. And it sends me over to the genomic data commons, completely different commons, and it opens up those 20 patients for me to look at. These are the genomic data that are publicly available on these patients. And if I had the right kind of authentication in the genomic data commons, I'd be able to come in here and actually look at the actual sequencing data for these kids. Now, of course, this is a very simple linkage, and we're very excited about the prospect of the next step, which will be to provide a cloud-based environment where users can combine our rich clinical data with these genomic data and to allow them to do the analysis in a cloud-based environment. And so we're working with the Genomic Data Commons, we're working with the Gabriella Miller Kids First group and other groups to try to figure out how we can best integrate our very rich clinical data with the data that are in their commons. I'll go back to my slides. Just wanted to show you that very brief demo of the platform because we're so excited to release it. So back here. Okay. So now I want to tell you a little bit about our genomic matching work that we're doing. And the name of the algorithm that we're working on, or the name of the program, is GEARBox, which stands for Genomic Eligibility Algorithm at Relapse for Better Outcomes. So I told you before that most kids most kids who get cancer will survive, but the cure rates for relapse and refractory cancers are not good. And it's been very difficult historically to match kids to phase 1 and phase 2 trials, especially when they're at relapse or they have refractory disease. And what happens often is when we see these kids, we don't have a phase 1 or 2 trial ready for them. And instead we put them on some holding chemotherapy while we scramble to do further testing and to try to match them to studies. And we need better and faster ways to match kids to trials that's based on the genetics of the tumor, on clinical information we have about the child, and perhaps even germline testing about the patient's own factors that will help us tell whether they'll respond to a therapy. We need a way to take these factors and to figure out which trials are out there and which trials might be a good match for this kid. And so we've been very lucky. The first big study that we're doing here is sponsored by Leukemia and Lymphoma Society. It's part of their pediatric acute leukemia or PEDAL initiative. And as part of that, we're building this GEARBOx platform. It's starting out as a web-based tool that clinicians can use to match children to available trials. And as I'll show you in some screenshots coming up, clinicians can filter those trials based on the clinical characteristics of the child and then other biomarkers like genomic biomarkers. The GEARBOx algorithm will then build a list of potential matching studies. And then what's critically important is then the clinician will be presented back with resources for how they can now learn more about the studies and get the child enrolled. So this is a much different paradigm, and it really is, it has the chance to be transformative, because as I described before, where you would have a child diagnosed with relapse and you'd put them on some holding therapy, imagine instead that you were able to walk back in the room and say, listen, I think your child may be eligible for these 3 studies. Let's find out right now which ones are open, where they're open, and how we can get your child enrolled within the next 48 to 72 hours. It has the chance to completely change the way we think about taking care of these kids. So the clinician, as Lucas showed initially, the clinician is presented with a screen where they can enter some information about the patient, like their demographics, like their age, and some things about their disease, things about lab tests and genomic testing. And on the right is a list of clinical trials that are on our platform, and this list will get filtered. Now, the clinical trials that we'll include will be any trial that we can have access to the inclusion and exclusion criteria. Much of this information is available on clinicaltrials.gov, but we're going to work with the various sponsors to make sure that we have access where appropriate to as many trials as possible so that we can include any available open study in our list of potential matches. On the left, the clinician here has entered that the patient's age is 10 years old. They're 40 kilograms. The patient has AML. I put here that the patient has had 1 relapse and they're currently in relapse with 25% blasts in their bone marrow. And on the right-hand side of this screen, you can see that they've now matched 3 trials. They've also have 5 trials that don't have matches. That means that they're not appropriate match for. And there's still 1 study that you can't tell based on the data entered if they are a potential match. On the right is shown what happens when the clinician clicks that little arrow for the top trial, is we can make any information here we want available. We can link out to more information about the trial. We can send them to a nurse navigator that might be available. We can send them, give them information about where to call or who the PI of the study is. And again, the whole point of this tool is that a clinician who normally would be faced with a daunting task of trying to figure out what to do next for this child now has at their fingertips a very rich resource where they can now help get kids matched to trials and get them on the trial. We're very excited about the potential of growing this into something that's even more useful, where we could even bring in outside data on the child from the trial into the tool, information about their genomic sequencing or some of their clinical information. And so we could actually turn it from just a calculator to a real clinical decision support tool. And all of these are in our plans. And we're very grateful, of course, to LLS for sponsoring the first iteration of this as part of the PEDAL project. Okay, so I want to spend a few minutes talking about some of the thoughts I've had about where pediatric cancer research is going. And the things that I'm going to talk about are not just applicable to pediatric cancer research, they're applicable to all areas of cancer and actually all areas of medicine. I first heard Rob Califf, the former FDA chair, talk about these parallel universes that we live in. And that metaphor really stuck with me because as a clinician, I see this every day, that there's a clinical care universe where it's all about seeing the patient, collecting data on the patient, taking care of the patient, all the stuff that goes into the normal day in and day out of maintaining health and treating people who are sick. And that involves seeing patients in the clinic or the hospital, doing imaging studies, sending biopsies to pathology, and putting all these data into an electronic health record like Epic or Cerner. That's a very well-oiled machine. And we're very good at collecting data and getting it into tools like Epic. On the other side, we have this research universe, and the research universe starts with a protocol, and protocols most of the time are written in a word processor like Microsoft Word. They're then exported as a PDF, and that PDF is sent out to researchers to open a study. That PDF has to be manually mined to take out information about order sets and tests and inclusion and exclusion criteria. And so there's a whole host of manual steps that must occur to actually create the treatment order sets that end up in the clinical workflow. And then data need to be collected on those patients who are on the study. So those data are very often collected by hand. We often see people who on one hand will have a screen open with Epic, and then they'll have their other screen open with their data collection form, and they will literally be copying and pasting or retyping the values in from one system to another. These are very parallel universes, and until we can start thinking about these as one universe, we're really going to be missing out on an incredible wealth of data. So I'm going to tell you a few of the things that I think have contributed to these parallel universes and why I think the kind of work we're doing and the kind of standards development we're doing is really key to helping fix this problem. So the first thing we have to do is we have to do away with these manual processes. Writing protocols in Microsoft Word has to give way to writing protocols in an automatic protocol generator, something where everything can be computable. We have to stop having handwritten adverse event notes and binders that have handwritten information about patients that is in parallel to what's in the electronic health record. And we should do away with these customized systems that where somebody links to a pharmaceutical system that's completely customized to their own study. They have to log into that system and they have to enter data for that study. There has to be a generalized way of collecting data that's interoperable and that leverages standards. We have to promote the use of data standards, and of course, all the talks they've been about data standards. On the left is an example from the gene expression omnibus, where all the genomic expression data is stored as part of one of the government initiatives. And in here are all the ways that age is represented. There's 30 different ways here to represent age. Think back to what I showed you before. Why don't we just have that code that we use for age, that C code that's in the NCI's thesaurus? Then you don't have to worry about somebody that's writing age in all capitals or lowercase, or writes age in years or age of patient. You don't have to worry about that. But imagine trying to harmonize a bunch of studies where you have to now figure out that age, all capital age, means the same thing as lowercase age, comma, years. It's really difficult. So we have to do a better job using standards. And on the right is an example of all the different things we're up against when it comes to the different types of semantics. So for height, do you know if you're measuring height in feet or inches or in metric and centimeters? Same thing with weight, pounds and kilograms. There's so many different ways to represent data that we have to choose a standard, and we have to be explicit about which standard we're using so that if we need to interoperate, we can interoperate. I think about this information funnel that we have, which I think is doing us an incredible disservice. When we collect cardiac function for a clinical trial, we collect a single number. We collect that ejection fraction, the amount of blood that's ejected by the heart with each pump. That's a single number, and that forever becomes that child's cardiac function for that study. That ejection fraction came from a report, and that report was generated from an echocardiogram, which is a video study, a very rich video study of the patient's heart and their valves and all of their ventricle and aorta, atria, and all that information is extremely rich and could be very helpful. So why aren't we collecting that rich information and saving it so that years down the line, somebody could go back and they could perhaps study the effect of chemotherapy on the patient's valves, or study the effect of chemotherapy on other aspects of the heart? You can't do that if you're just saving the very bottom of that funnel, just that ejection fraction. So we must think about better ways to pull data automatically with technology like HL7 Fire or other methods to get the actual data out of the electronic health record and into our research databases. We have incredible information loss during transfer. Recently, or last year, we tried to bring in radiology reports into our commons. And we wanted these text reports to go against the images that we had. And the text reports that we got instead were actually images of the text report. And when we looked into it, we found out that the way that the data were collected was that the hospital was faxing a report to the central agency, and the central agency was then scanning that report into a picture. We had to take the picture and we had to do optical character recognition and then natural language processing to get the meaning out of the report, instead of what we should have been doing, which is getting the actual reports from the electronic health record into our system. So think about the waste of information and the loss of time in doing these kinds of maneuvers when we really should just be going back to the original source and getting the original data. As I said before, we have to eliminate this manual data transfer. This actually still occurs where a cytogenetics lab will do tests and they will send the report to the hospital, often by fax. The hospital then takes that fax or that PDF and puts it into their electronic health record as a PDF report. And then the clinical research assistant has to take that PDF and manually key the values into a case report form. Now imagine instead a world where we have computerized interfaces that automatically move the data from the lab into a data commons or into the hospital's electronic health record. There's so many better ways to do this that were invented many years ago. And so we have to get through the socio-political issues and actually get to a point where we can do this at scale. Think of all the time it will save and think about how much more rich the data will be. This final example I have is, it shows how difficult it is to match data, even if it's coded. So, the codes for lab values use a system called LOINC. And here are all the values all the different types of hemoglobin that are in this hospital's electronic health record. And you can see that there's 15 or 20 types of hemoglobin here, each matched to an appropriate LOINC code and each meaning something different. On the right, you can see that they're all different types of hemoglobin that are measured. If you're the clinical research assistant for a study and the study just says, what is the hemoglobin at the start of chemotherapy, you have to know exactly what you're looking for. And so trying to standardize this and trying to harmonize how we do this is really important, because how can you have an automated system for pulling out the hemoglobin at the start of chemotherapy if you don't know which hemoglobin you need? And it may be different from hospital to hospital, because the next hospital may or may not be using LOINC. And if they are, the LOINC codes may have different text descriptions of them. So we have to be very careful how we do this. And there's a real opportunity here for standardizing how we collect data and how we report it. So I think the one universe that we need to achieve is going to be difficult. It's going to take time. There needs to be sticks and carrots, but there should be a way to write protocols in a protocol generator, and that protocol generator should write a protocol that can be automatically parsed and should be used to generate the orders and generate the tests. We should be able to take data automatically out of the health record and put it into the data commons, and then serve research databases and serve electronic data capture for clinical trials. And we definitely need to be thinking about how to collect real world evidence, data from cell phones and wearables and surveys. We're not doing a good job at this right now. The technology is there. The standards are emerging, especially with the kind of work that we're doing. And I think there's an increasing appetite to do this type of work to achieve this one universe. And when we do this, think about how much more rich data we're going to get, how we're going to learn from every single child. Every part of their care is going to be something that we can take and use for further research and we can learn from. I want to say a few words about addressing global gaps in cancer survival, because I think there's an important role for the data commons to play there as well. This is a quote from a recent paper. 90% of the world's children live in lower middle income countries, and they account for 95% of the mortality from cancer. I think this is pretty startling that we keep talking about our survival rates in the US or in Western Europe, but most of the kids who die of cancer, of course, don't live in these areas. Most of the children, or many of the children who die of cancer, are never even diagnosed with cancer. So what this graph shows is that in the lightest color, these are areas where almost all the kids who have cancer are diagnosed. And as the colors get more red and get darker, these are areas where, you know, at its worst, you know, only 20–30% of kids who die of cancer are diagnosed with cancer. So think about that for a second. You have children who are dying of cancer, you know, they get fevers and they have leukemia and get fevers and then die of infection, and no one ever knew that they had cancer in the first place. So there's obviously a lot of opportunity here for improvement. And of course, the WHO and other groups are working on trying to improve cancer survival rates for these kids. Why do kids die of cancer in various areas of the world? Well, if we look at the high income countries, the dark blue here represents the 80% of kids that survive cancer, that are cured. The purple there is kids who relapse from their cancer, and so that's another cause of treatment failure. As we move down to the bottom, looking at lower income countries, there's only a small proportion of kids that are cured of their cancer, and there's a majority, almost a majority of kids that never receive a diagnosis. And amongst the other reasons are kids that don't receive treatment, they die from toxicity, they're diagnosed with the wrong cancer, and so forth. So there's an incredible opportunity here to improve the treatment of kids in these areas. Now, the PCDC, of course, can't fix this problem, but we really think that the tools and the resources and the education and training and all the work that we're doing can really go to help others in their efforts to address this gap. We welcome researchers from all over the world, as we have been, to try to continue to help us to improve these tools and resources to help others. Data standards and the data lifecycle are really important to this process. Data will inform scientific discovery, policies, where money is spent, decision-making. And if the data are inaccurate or incomplete or just of poor quality, it can misinform and distort how resources are allocated and how different initiatives are prioritized. The use of data standards and the attention to the lifecycle that we're promoting helps improve data quality, improves completeness. It ensures that every patient that has cancer, their data can contribute to research and can contribute to helping to study the types of cancer that they have, and can help guarantee that that resources are accurately allocated to different areas to achieve the maximum benefit. So we're passionate about how the data standards and the data lifecycle are going to be incredibly important to addressing this problem. The PCDC, we think there's some very specific things that we can do to help address and close these gaps. We can advocate, as we have been, to facilitate the use of global standards by mapping to standard codes, by promoting our data dictionaries, by making sure everybody has access to them. We're trying to serve as a hub for experienced and new investigators, where we can offer education and training and access to data. We can provide the different disease groups, consortium management and governance to cultivate these international partnerships. It's so wonderful to see new groups coming in all the time that want to join these efforts, that want to contribute data, and to provide the governance to do that is something that I think is very important for us to do. And developing new analytic techniques, and as I said before, being able to develop an algorithm and share it so that other people can use it is critically important. I want to say a few words about the integration, integration with the national efforts in the U.S. So this is a picture that I think many of you have seen in my talks. This is a view of what the national landscape for cancer research data commons looks like. So in the cloud there at the top are all the interacting data commons and the tools that go along with it. There's the proteomic commons, the genomic commons, and so forth. And on the bottom are all the users of these commons: clinicians, computer scientists, researchers, and so forth. And this is an ever-growing set of interacting commons, and we are very excited to be part of this ecosystem that is growing up for collecting and sharing and analyzing cancer data. One of the ways that we're participating is we're actually leading or co-leading the Center for Cancer Data Harmonization, which is a contract from the NCI, where our group is working with other groups from the institutions listed here to facilitate harmonization across these different groups, to coordinate the community around using these tools and using the data, and to find agreement on standards across these communities. And our group is perfectly positioned to help because we've devoted ourselves to developing these standards and educating the community. So we're very excited about doing this work. It puts us on the national stage in the US to be part of these discussions, and it allows us to take the work that we're doing and integrate it into the national conversation. The Childhood Cancer Data Initiative, I'm sure most of you have heard of. It was announced in 2018, a $50 million a year for 10-year initiative to promote to promote better ways to collect data from children with cancer. The idea is to maximize every opportunity, every interaction that a child has with the medical system, to build a connected infrastructure of tools and data and enable sharing, to figure out better ways to make the data work together and to build better tools and to share those tools. Much of the stuff that I've been talking about today is exactly what the initiative is about. There are many different groups that are collecting data that have to do with pediatric cancer. I've listed some of them here. Many of these will be familiar to you. And the graphic is really just to illustrate that we need to connect these groups together. I showed a very simple example of the pediatric cancer data commons at the top, connecting to the target database on the lower left. But we really need to think about how all these groups are going to work together, how we're going to connect across them, and not only connect, but to aggregate and to share data so that everybody is enriched through this process. One of the main initiatives of the CCDI is the National Childhood Cancer Registry, the NCCR. And the NCCR is a really audacious plan to collect information on all kids diagnosed with cancer through the cancer registry process, to consolidate and standardize those data into a single infrastructure, and then to provide a way to give those data back to researchers to analyze. The different types of data here are listed below, and our group has taken an active role in helping plan and organize this effort, and we are part of a lot of the phone calls, and we're helping advise some of the groups that are contributing data. So we're very excited about working with Lynn, Joanna, and others who are part of the NCCR in helping make this a success, because we agree that it's critically important for everyone to collect these types of data and to have it standardized and to collect it and put it into a central place for research. So just a word about sustainability, something that we always get asked about, and it's extremely important, always on our minds. The long-term viability of the commons, of course, relies on funding. And we spend so much time talking about funding and how we're going to fund the next project and what grants we're going to apply for and what gifts we can try to get. Funding is critically important, and none of this would happen without the extremely generous funding we've received so far. We also have to make sure we remain relevant. We have to make sure that the work we're doing is interoperable and it works with other groups out there. If there are other groups that are doing similar work to us, we should work with them. We should try to improve each other and make sure that whatever we're doing stays relevant across the international stage. We have to make sure that there continues to be cooperation from our partners, and we do that through promoting trust, by having a governance where people really understand that when they contribute data, it's going to be used in a way that adheres to the rules that were set forth. We are always looking for new and ongoing partnerships. As I said, we've had many new groups now emerge from different parts of the world that want to work with us, and we're so excited to bring them in. And we're trying to figure out ways to integrate these groups into our ecosystem. And then the community support and engagement is absolutely critical. And I don't mean just from the other clinicians and researchers. I mean from parents and advocates and groups that advocate for how we collect and use cancer data. We are so reliant on this type of community support. It's so gratifying to see such a wide and diverse group here today. And we really rely on this engagement to keep going. So just finishing up here, just with some ideas about how to get involved. We want people to work with us. You can join the conversation by signing up for our newsletters. You can come to our webinars and our workshops. You can even join our team. We have several jobs posted. We're going to be hiring everything from programmers to data standards experts. So we want people to look at our job postings. And if you know somebody who might be a good fit, please send them our way. We are in dire need to grow the team right now. We have so much work that we want to do. So please take a look at our website and see what might be applicable. We encourage researchers to use the data commons. You can write to Kat to figure out how to get involved in a consortium or one of our work groups. As you stay tuned with our newsletters, you'll know when the Gen 3 launches, and you'll know when that's available for research. And as I mentioned, our completed data dictionaries are available for download and for sharing, and we encourage groups to take them and to use them. And as more and more data dictionaries are built, we'll be posting them for people to use. And of course, we have to try to sustain the work. So if you have ideas about how we can raise other funds, please, talk to me or Monica, or talk to Bobby, who's from development, to learn about other ways to support the Pediatric Cancer Data Commons. We hope that groups that fund other types of cancer will, other types of research will integrate into their requirements the use of data standards. It's really important that as RFAs and RFPs are written, that they include language that tells the groups that are doing the research that they have to adhere to data standards and they have to share their data once it's collected. If more and more groups did that, then it would become the expectation. And I think we need to really encourage that. And of course, as I mentioned, helping to raise funds with your local groups and your parent networks and your advocate networks is really important to us. So with that, I'm going to stop there. I'm going to stop sharing. I see a lot of questions in the Q&A. I'm going to hand it back over to Monica, who's going to moderate, and look forward to hearing from those of you who are here.
Perfect. Thank you so much, Sam. And as he alluded to, we do have several questions, as well as I know a few people submitted questions during the registration process. So we will get to as many as we can in the next 30 minutes, but feel free to continue using that Q&A function, and we'll get this conversation started. So Sam, I'm going to start with one of the questions that was just submitted. I know that we kind of glossed over it earlier, but one of the questions was, is St. Jude's fully engaged in the Pediatric Cancer Data Commons process?
Sure. So I'll start with that, and I'm actually going to ask Susie to weigh in as well. We've been really lucky to work with the folks at St. Jude over all different types of cancer, and I think we're very close to starting to integrate some of the St. Jude data into our own commons. And the idea here, of course, is to try to leverage the strengths that we both have. So St. Jude, of course, has data that is not part of the Children's Oncology Group data that we have. So we'd love to pull those data in, and then we'd love to give back to St. Jude the harmonized data that comes into our commons for their own purposes and to connect to the genomic data they have. But maybe Susie, do you have a more specific answer about how our interactions going?
Yeah, thanks, Sam. I do. We are actively working on data contributor agreement with St. Jude that would allow us to pull any of their diseases into any of the commons that they would want to. Currently, of the 10 diseases that we've talked about today, 3 which are active consortia, Hodgkin's, which is nodal, neuroblastoma, which is INRG, and AML, which is Interact. All 3 of those have St. Jude as founding members of their, or active members of their consortia. Neuroblastoma having them just joining that now. And 2 that are in development, retinoblastoma, which is Global Reach, and C3P, which is the Cancer Predisposition Commons. They're also engaged in both of those. So that's 5 of the 10 diseases we're in active discussions. And we thank them for all of their hard work.
They've been wonderful, wonderful collaborators. Thank you, Susie. Thank you, Sam. Next question, also actually by the same individual, but Sam or Brian. The attendee is wondering, how successful has machine learning been when applied to the data that we've collected?
Yeah, so we're starting to see more examples of applying machine learning. One of the attendees today, Mark Applebaum, is actually working on a study where they're doing some image analysis over some neuroblastoma images and comparing that to the clinical data we have to try to understand, can you do some prediction about outcome based on diagnostic images? So as we collect more and more data, we are definitely going to have more and more folks that want to apply machine learning techniques so that they can help develop classifiers or help develop other predictive models. Of course, you need hundreds of thousands of data points to apply most machine learning techniques, and I think we'll get there. Pediatric cancer is uniquely challenging because of how rare it is, but I think over time, especially with the genomic data that we have, we'll have more and more applications of machine learning to pediatric cancer.
Perfect, thank you. We've got another question from Mark over in Australia, so thank you for waking up early with us, Mark, this morning. Mark says, towards global harmonization, are there clinical data dictionaries readily available across the range of pediatric cancer types mentioned at the start?
Would you want to take that, Monica?
Yeah, I can. Yes, I can absolutely take that. So Mark, the answer is yes for most of them. Right now, we're still finalizing a few with the National Cancer Institute's thesaurus team. And so the ones that are available, if you go to our website, which should be commons.cri.uchicago.edu or commons.uchicago.edu. It'll be in all the materials we send out later. You should be able to go to the disease group and consortium specific pages, and the data dictionaries, which are completely complete and finalized and mapped to the NCIT codes, should be linked on those respective disease group pages. We're actively working to, thank you, Sam. We're actively working to update the individual disease group pages and consortia pages for all 10 of our groups. If it's not, if the data dictionary that you're interested in isn't currently available on the website, please feel free to email Kat Blumhart on the screen right now, or myself, or Susie Burrs, who manage the different disease group consortia, and we can tell you where in the process that specific disease data dictionary is, and we can give you an estimated completion timeline for it. But as soon as they're ready, we have been putting them up on the website. And with that, I am going to move up to a question that was submitted from Liz Jackson when she registered for the webinar, which is when do we plan to incorporate electronic health records? I think we might have touched on it a little bit.
Yeah, I think, we're very excited to start bringing in electronic health record data. And for some diseases, especially like retinoblastoma, where there isn't a lot of clinical trial data, we're going to be really relying on registry data and electronic health record data. As I mentioned, the technology is there, and one of the initiatives, I think, as part of the CCDI will hopefully be trying to get closer to electronic health record data, because I think it's critically important to leverage this very rich data source. As you know, clinical trial data is highly curated. It's collected to meet specific aims. But if we can really get at electronic health record data, we can collect the entirety of a patient's diagnostic information and really learn a lot more. I think we're close. The issues, again, are not technical. And I think that we'll get there soon.
Thank you, Sam. I will direct this one to Brian, if you wouldn't mind. Are the software tools we are building open source? Under what licensing model?
Right. So we have been discussing this, and I think we're settling on a non-commercial Creative Commons license for the data dictionaries and the tools that we're building.
Which is to say, yes, they're all open source, right?
Yes, for non-commercial use.
I think the official title is the CC BY. We've been running
CC BY NC.
Yeah, everything we build, we want to fold back into the community. That includes the dictionaries, the tools we develop, and then the extensions to the Gen 3 platform.
All right, thank you. Next question. The GEARBOx tool sounds incredible. Will it include trials in specific regions, for example, the UK or just the US?
That's a good one for you, Monica, unless you want me to try.
I could take a first stab at it. So the short answer for right now is yes, the GEARBOx tool, I would agree, is incredible. And thankfully, the Leukemia and Lymphoma Society has been funding us to work on it, starting with the US. And so this is actually an active conversation with the leadership of the PEDAL initiative there. We would love to be able to expand it to Europe. We're just working through the details and logistics and budgeting of how that might be feasible. And so we would love to expand it. And I know Sam, has big plans for what this tool can be used for ultimately. But we need to take a strategic approach to what's the most important next step, and how can we roll it out in a responsible and useful way to researchers.
Yeah, I mean, I think there's obviously going to be regulatory issues, but I think the vision of everybody involved is that this tool should be available as widely as possible, if it can be done safely and it can be done in a way that's governed correctly. And we're really hopeful that we'll have partners from all over the world, not only contributing clinical trial information, but also using the tool for kids that they have in their clinic.
So looking at, hopefully that answered it. If not, please submit another question. Looking at a question, How do you see, oh, okay. The comment is, I couldn't agree more with you on how critical it is to create one database and integrating the information available through various platforms that exist. How do you see that coming together? What are the biggest obstacles? What kind of time frame would it take to make that happen? It seems like a daunting task, but so important.
So, we have a couple bottlenecks to the work that we do. And, one of the bottlenecks is getting our regulatory issues sorted out. And you can imagine just sharing data between hospitals in the US can be challenging. Now imagine trying to share data with 30 institutions in Europe or across Asia or South America and so forth. So getting adhering to HIPAA and GDPR and getting the regulatory aspects in place is incredibly time consuming. Susie spends full time on doing this, working with lawyers from all over the world. She speaks lawyer like nobody else now. And it really is time consuming and meticulous work. So that's one of our biggest bottlenecks. And we're working through those. We're trying to develop some repeatable processes and pipelines. The second bottleneck we have is in harmonizing the data. And I think it's important to mention this because we could definitely use the community's help in understanding how to tackle this better. Data have to be harmonized into the new standard to be interoperable. That harmonization is best accomplished by the groups that collected the data. Well, these groups often don't have the effort to sit and to meticulously map data to a new standard. So sometimes we're asked if we can do the harmonization, which is yet another challenge. So this is both a human resource issue as well as a funding issue. And that's one of our main bottlenecks. We would have a lot more data in the commons if it was easier to do legal agreements and if harmonization was easier. When I first started this, I thought the bottleneck was going to be getting people from around the world to work together and to build the dictionaries. We're doing that like crazy. We have dictionaries for almost every disease now, and people love working together. And instead, we have these other bottlenecks. But I think as we start to bring more and more data into the commons, we're going to see these barriers break down. And I'm very confident that over the next year and a half, we're going to see an incredible rise in the amount of data we have. Then I think there's going to be this. We talked about the global gaps. Then there's going to be this really important process of deciding how do we integrate some of the areas of the world that have not traditionally collected data that was used for research, because we think it's really important to engage these groups, and how we integrate those groups into our work is going to be critically important. So lots of areas to work on, and I hope that sort of gets a little bit at answering your question.
Thank you, Sam. Next question is there a standardized technology equivalent to Gen 3 developed for the National Patient Registry?
Yeah, so the National Cancer Registry is still being developed. It's in its infancy, and there will be a way to store and share data through that. And I don't think that a specific platform has been chosen. I'm certainly happy to connect you with the folks that are as part of those discussions about the infrastructure. Gen 3 is one of many different types of platforms. It would make sense, like we're using Gen 3, it makes sense to us to interoperate with the other parts of the commons. So I would hope that as NCCR develops, that they're similarly able to leverage a technology that allows them to interoperate with other parts of the data ecosystem.
Perfect. These questions are wonderful. I encourage participants to keep them coming. In the meantime, we'll hop back to a question that was submitted during the registration process from Leona Knox at Solving Kids Cancer in the UK. And Leona said, how can we increase understanding of the importance of data collection to help accelerate research, especially with rare disease patient communities? So I know, Sam, you touched in your slides a little bit about some of the more rare pediatric cancers that we still need to incorporate. Can you speak to a little bit more to the importance of those data in particular, and what groups like us can be doing, and how the advocates in these communities can have a role to play in it?
Yeah, I think the tools that we've built to allow the discovery of very specific cohorts, I think, is going to allow a new type of research that hasn't been available in the past. It used to be if you wanted to study a very rare cohort of a pediatric cancer, you were lucky to get together a dozen patients. And now that we're bringing together data from all over the world, I think it's going to be very possible that these cohorts are finally large enough to do some real analytical studies on. But the other half of it is getting the word out. It's getting out the word to groups that we have the data. It's getting the education and training out. It's having the governance in place so that somebody from one corner of the world can come in and access data that was collected somewhere else. I mean, that's not a trivial type of governance to put in place. So all these pieces have to come together, but I think that we're really going to change the paradigm for how ultra rare diseases are studied. Oh, and I will say that the parent advocate groups are absolutely key to this, because there are pockets and registries of data all over the place that I'm learning about all the time. And we would love it if people came to us and said, hey, we know about a registry with 60 patients over here. Can you work with them to integrate their data? I mean, that's a dream for us to try to get those data into our commons. So I would encourage people to come to us if they have that information.
Thanks, Sam. Another data standards, I think, related question. Well, maybe not data standards in particular, but the question is the PCDC or Center for Cancer Data Harmonization in touch with the OHDSI, OMOP, and or MCODE Codex initiatives, which are also working on cancer data standards?
Sounds like a Brian question if I've ever heard one.
So yes, we certainly are in touch with these various initiatives and keep track of how other people are coding these things. And as we especially start moving into areas of hopefully being able to capture more granular information about treatment regimens and things like that. I know that HEMOC.org has been working with the Odyssey community and getting their treatment regimens into the Odyssey vocabulary. So yes, we are certainly paying attention to things like Odyssey and ENCODE in particular.
Thank you, Brian. Let's see. I think we have addressed all of the questions in the Q&A. We can address one more question unless there's others that people would like to submit. This question I will direct to perhaps an open question for the team to have a discussion about. But are you concerned or worried about security and patient privacy? How do you protect data from misuse? I know that Susie touched upon this with some of the fences in the governance section, but I think this also is addressed in some of our technical team's work. So I will perhaps let Susie start in terms of patient privacy and security. And then I will maybe let Brian or Luca follow up with how we protect data from misuse.
Thanks, Monica. So we take patient privacy very seriously. We've created this data commons, and it's of de-identified data as that's defined in the United States under HIPAA. And we know that globally, that definition is not the same from country to country or region to region. And so when we negotiate the data contributor agreements and we discuss the data that will be sent to the Pediatric Cancer Data Commons, we're very careful to ensure that we're able to continue to meet the United States definition of de-identified data, as well as to meet the requirements of regulatory issues around the globe. And all of our contracts that we enter into ensure that we know what those requirements are and that we pass those requirements on to our data users. In particular, every data use agreement contains exactly the proposal for which those data may be used. And this, like every contract, you can't stop bad actors. But what it does do is it makes everyone aware of the risks and the responsibilities associated with having those data and what they have to do to protect it and to notify us of any misuse, intended or unintended, that may occur with the data. So that's the governance fence.
Yeah, I don't know if Luca, you want to speak to how the Gen 3 infrastructure authentication and authorization systems are in place?
Yeah, I can take that. Well, a user will be able to see only aggregated data on the platform unless goes through that approval process that described before in my slides. And only once an executive committee will approve the project request from that user, the database will be populated with the IDs of the subject that the user is allowed to see, and only then the user will be able to access line level data for only those subset of subject in the platform.
Not, and also so far all the data we've received are completely de-identified. So we don't even have dates. Everything is done in age and days, and we don't even have geographic locations for the patients. So the chance of a re-identification is very small, but nevertheless, we treat the data with the highest standards to make sure that that privacy is protected. It looks like there's a follow-up question there, Monica, about data access, which I think is applicable.
Yeah, so the question is data access granted institutional based or individual licenses can be issued as well? Perhaps Susie, this might be one for you.
Hi, sure. So I want to make sure we're talking about how we're defining data access. So Luca has described data access to cohort discovery. So any individual can register and do cohort discovery and do the analytics. As far as getting the data, an individual investigator or a team of investigators can put in a project request. And when the project is approved, wherever the data is going to be analyzed, whether it's going to a clinical investigator or it's going to a statistician or a bioinformatician, where the data are going, the University of Chicago enters into a data use agreement directly with either the institution in the United States, because the assigning authorities are always institutions, or it could be directly with the investigator. In the case of Europe, the investigators have authority to sign and enter into those agreements. So it really depends on the geography where those agreements are. But generally, it's University of Chicago to the institution, and then each project. So if there are multiple investigators at an institution, for instance, here at Dana-Farber, we have multiple investigators who are using neuroblastoma data. We have one data use agreement, and we have multiple addendum attached to that describe the particular project and the data that are released for that project. I hope that answered the question.
Great, thank you, Susie. I just want to also, we're lucky enough to have Jamie Alvo here from the NCI. I just want to address her question real quick too. So Jamie asked, with so many separate access committees, how do you foresee making sure data are approved in a timely fashion? It's a great question. And we've really we've really moved to the side of having rigid governance in place. It was the only way to get the kind of trust we needed to get the data. We do have really streamlined processes for having people apply and get data. But as we know, the ultimate will be to have data that are available, even closer to what it's collected. And I think for certain sets of data, especially those that are collected under certain conditions and certain sponsors, data will be available much more quickly and under much easier conditions. But we had to start with a process that was a little bit more controlled. And I think over time, we're going to be able to ensure faster access to data. We give out data all the time with the right controls, and I only see that getting easier over time.
I think, Jamie, this is a perfect question to address the reason behind creating the Scientific Advisory Committee and External Advisory Board, is that these are types of things that as the PCDC progresses, those representatives from the individual disease group consortia can learn together and say, if people make a multi-disease group data request and that process is onerous and delayed to get approval from all of the necessary people, how can they advise us to responsibly improve that process or streamline the workflow? But it really requires the approval and the consent really from each of those individual disease group consortia and the data owners within that consortia. So we're really excited. I think that that's one great example of what we can do now with the Scientific Advisory Committee once it's stood up. And so, yeah, we're very excited for this stage. But I think as you point out with that question, there's a lot of cross disease group questions that still remain. This is a new endeavor, and it involves a lot of global representatives who should retain ownership over their data and that control. And so if we need to speed up or slow down the process, we'll work with them on that for sure.
Great. All right, so thanks everyone. So while Monica transitions to the last slide, because I think we're up on the hour now, I want to make sure I give a special shout out to Caitlin Pike, who really has done most of the organizational work you've seen here today, and is really been the driver of getting this organized. So we're very, very thankful to her and her organizational prowess and her communication skills. So thank you, Caitlin. I'll leave it to you, Monica, to take us out.
Yes, so it wouldn't be a PCDC meeting without a list of next steps and action items. For those of you who are familiar with working with our project managers. So as Sam said, we're so grateful again for everybody who stuck around or joined us for any portion of this webinar. If you have additional questions, please don't hesitate to reach out to me. Our contact information for many of us is also available on our website, again, commons.uchicago.edu. If you want to receive the quarterly newsletter, I know several of you signed up during the webinar, but you can go to the short link at sam.am/PCDC news or register at the main page of our website. That is our second annual PCDC webinar, and we thank you for joining us and look forward to seeing you again in the upcoming months.
Thanks, everybody.